Hello everyone. Now we are going to see about the continuation of the part that is the post antepartum hemorrhage, and in that antepartum hemorrhage we have seen about and abruptio placenta. Now today we are going to continue about the next part, that is placenta previa. So in that APH, the maximum cause it is the placental bleeding. In that placental bleeding, one is the antepartum hemorrhage, and second is the first one, the placental bleeding, it is the abruptio placenta, and second one is the placenta previa. So now, and there may be some other causes also, that may be unexplained causes, or it may be some uh, extra placental causes. So today we are going to see the second part, that is the placenta previa. Okay, so in placenta previa, what we see that uh, what is it actually? So it is the problem in abruptio placenta. What we have seen it, the placenta it is situated in the normal side. But what happened over here? There is a early separation of the placenta. While in placenta previa, what is the situation? The placenta, it is situated in the lower uterine segment. See, it is in the lower uterine segment. Normal situation of the placenta, it is not lower uterine segment. Actually, it is upper uterine segment. So it is the lower uterine segment. And what happened? About one-third cases of the APH, that is antepartum hemorrhage, it belongs to that of placenta previa. And what is the incidence? So if we say the incidence, it is 0.5 to 1% among the hospital deliveries. Whatever the hospital deliveries, we see that. So out of 100, 0.5 to 1% females are antepartum suffering from that of placenta previa. And in 80% cases, it is found in multiparous woman. Multiparous who is giving birth to the child for 2 to 3 times, then it is multiple, maximum, multiparous woman. So what is the reason, etiology? So if you say that what is the cause behind the implantation of the placenta, what is the reason so that the placenta goes into the lower segment? It is unknown. We don't know it, but there may be some risks which are present to this. It is the following reasons. That is, it may be some advanced maternal age. This may be applicable for the abruptio placenta. Then there is a multiparity. Then second, next maybe there is a multifetal and multiple gestation. This is also applicable for the previous, that is the abruptio placenta. Then what happens? There may be some multifetal or multiple gestations, prior cesarean delivery, if there is a history. So in that, we have to ask related with the history of LSCS in the previous. So that history, obstetric history, we have to ask it. Or if the patient is having the smoking, this is same cause is applicable for the abruptio placenta also. In that we have seen the cocaine history or the smoking history is responsible for it. And then prior placenta previa, that is similar history of placenta previa in the previous gestation also. And sometimes it may be the anomaly of the uterine structure, that what we know that there is some congenital anomalies in the uterus shape itself, because sometimes there is maybe septum or whatever the shape of the uterus, it is not normal. That can lead to the placenta previa. And then the assisted conception, that is the, there may be if other assisted conception is there, that is if you use the additional technology, that can lead to this placenta previa. Now, clinically see, in abruptio placenta, what we have seen, the placenta, it is in the upper uterine segment, while in placenta previa, the placenta, it is in the lower uterine segment. What is lower uterine segment? This part, it is upper uterine segment, and this is lower uterine segment. And see the degrees what we are seeing over here. This is lower uterine segment. So first we are seeing upper uterine segment. We have seen in the previous, yes, in this diagram. See, it is upper uterine segment. Placenta is attached. This one is upper uterine segment. And what is lower uterine segment? In this diagram, yes. So what we are seeing is it is the lower uterine segment. But again, it is divided into four parts. What is it? It is the lateral. Lateral means having some distance from this os. So this is a little bit of distance from it. So this one is the type 1. So when it is present at the margin of it, then it is the type 2. It is just margin to it. So it is the second one, marginal variety. Then when the os is closed, it covers the placenta is covering. So this one is os is closed, placenta is covering. So that is type 3. And this one where it is entirely, it is in the lower segment. So definitely this is not from here the normal labor, it is not going to take place. So this is complete, this type 4, it is complete. So this type 4, it is the complete one. So these are the types of degrees of first, second, third, and fourth variety. So just what we are seeing, see the name from it. It is the low-lying placenta or lateral. Second one, it is the marginal. Third one, it is complete or partial. And fourth one is central, or here it is the partial central. Here it is the complete or total central. So how it is? What happened? Here in the low line, the placental age is in the lower uterine segment. It is present everywhere. We are seeing the in the lower uterine placenta. It is in the lower uterine segment, but it does not reach the internal os. So that is why it is called as a lateral in this diagram. It is this one is the internal os. What I am showing from this diagram. This one is the internal os, and what we are seeing is a little bit of distance from it. So that how can you think about it is the lateral variety. While in second one it covers the, it is present in the margin of the internal os. So the placenta reaches the margin of the internal os but does not cover it. That is in second variety. And it is divided into two parts. That is it's divided into anterior and posterior. While in third variety, that is incomplete or partial central. The placenta covers the internal os partially, covers the internal os very close, but does not entirely do when the fully dilated. So this is the when the os it is closed, so it is covering it. But when the os it is open, it is not covering it. So that is why it is called as a partially covered, okay, or partially covered. While in this case, whether it is os is completely open, closed or open, doesn't matter. It is going to cover the entire os. That is type 4 variety, placenta previa. See, central or total. The placenta is completely covers the internal os even after it is fully dilated. So there is no question of whether os is open or closed. It is going to cover the entire os. That is fourth variety. That is central or total placenta previa. Now question arises, why there is a bleeding? What happens that it leads to that of bleeding? So whatever the bleeding which comes in the before the delivery, that is bleeding results from small disruption of placental attachment during the normal development, and that of the thinning of the lower uterine segment. Because what we know that it is the part, this part becomes thin afterwards, and it leads to the dislodge from this side. That leads to the cause of the bleeding. The next one is As the placental growth slows down in latter months and the lower segment progressively dilates. So what happened here? The lower segments as the pregnancy advances. So this lower segments it is dilates. It is increasing in size. So it leads to a problem. Bleeding takes place. So placental growth slows down in latter months and lower segment progressively dilates. And the inelastic placenta. Placenta is not elastic like a rubber. So it is an inelastic placenta. So it shreds off the wall of the lower segments. And this leads to the opening up of uteroplacental vessels and it leads to an episode of bleeding. So in that we know that means as the pregnancy advances, this lower part it is increasing the size. It is dilating. But in same fashion, placenta is not increasing. Placenta is it is inelastic. It is going to remain the same. So it dislodged from this. This whatever there is a separation of this. Whatever the vessels which gets open leads to the bleeding from this. So that is the cause for bleeding in the placenta previa, which is the nothing but the bleeding which takes place before the delivery. That is called as antepartum hemorrhage. Then how can you clinically judge? So if you see any female pregnant lady of 7 months, 8 months, and that the bleeding is usually mild, it is not a severe bleeding. But it sometimes it could may go into the severe or recurrent and painless and causeless bleeding. There is a no pain in it, and it is whatever it may be soft and non-tender uterus. So if you do the per abdominal this one per abdominal examination and this, so in that soft and non-tender uterus, it is normal fetal heart rate. It is unless there is a severe bleeding or associated of abruption. So if it is not abruption, then the fetal heart rate it is going to be normal. There is no any changes in the FHS. While high presenting part and the fetal malpresentation. So whatever the normal presentation, it should be the vertex should be present outside. But in that, it is opposite. That is maybe bridge may be present or fetus may be in the presence of some transverse or oblique line may be present. So it general condition and anemia are proportionate to the visible blood loss. So we have to see the general condition of the patient, that is her blood, pulse, BP that we have to see, and the anemia depending upon the how much of the blood loss is going to be there. So if you see the abdominal examination, so there is a height of the uterus, it is exactly proportionate to that of period of gestation. So there is no any problem. And whatever the uterus, it is feels relaxed, soft and elastic without any localized area of tenderness. So no pain. Patient just whatever the patient will do the per abdomen, there is no any pain, but there is a per vaginal bleeding is there. So we can think about it, maybe BPH. And but on this and ultrasonography, we are going to judge it. And the persistence of malpresentation, we know that there is a moment which takes place, but before the delivery, it is the vertex presentation. Okay. Vertex presentation is common during the delivery. But here it is the malpresentation. What is meaning of mal? Anything, any presentation other than the normal presentation, that is the malpresentation. So there is an increased frequency of there is also increased frequency of twin pregnancy, and the head is floating in contrast to the period of gestation. So there is a floating head, whatever may be the period of gestation, and the head cannot be pushed down into the pelvis. Normally, head is pushed down into the pelvis, and in normal one, the head is trying to get engaged. But here, it is the fetal. Here there is a floating, and there is a head cannot be going to downwards because the placenta is in between, and the fetal heart sound is usually present. There is no problem for purposes. On vulval inspection, if you see, there is a blood is present, and which how is the color? It is going to be but of this the bright red color as the bleeding occurs from the separated uteroplacental sinuses. So close to the cervical opening and escapes out immediately. What is why the blood it is bright red? Because it is immediately coming from this side. It is immediately coming. So when it is a fresh color, fresh, it is going to be, it is the bright red blood. It is going to be there. Then vaginal examination, it is the contraindicated. It is not allowed to do in the placenta previa. So diagnosis. So if we see the diagnosis, uh, diagnosis painless and it is recurrent vaginal bleeding in the second half of pregnancy. That is afterwards. Should be taken as a placenta previa unless proved otherwise. And basically, ultrasonography is the initial procedure either to confirm or to rule out the diagnosis. So if you see that any female comes in the second trimester and present with that of the pain bleeding and there is no pain, patient does not having any pain. So we have to think about it, maybe placenta previa. So what we have to do it is the ultrasonography. For what reason? To confirm it or to rule out the other diagnosis. So on the localized of placenta, there is a sonography. There are different varieties of sonography. That is transabdominal sonography, that is TAS, TVS, that is transvaginal sonography. Then that is transperineal ultrasound and the color Doppler flow study. And sometimes we have to think about the MRI, that is magnetic resonance imaging. And next one is that is a clinical proper examination. We have to do it. So in clinical examination, by just doing the internal examination, that is double set of examination, direct visualization during the cesarean section, that's what we see that examination of the placenta following the vaginal delivery. So confirmation of diagnosis, so it is the localization of placenta and by the clinical. So this what we are seeing by the transabdominal, transvaginal, transperineal and color Doppler and MRI by internal double setup. It is the direct visualization during cesarean section and the examination placenta. So if you see, so this in ultrasonography, they are confirming that is the placenta, it is in the lower uterine segment. So this ultrasonography color Doppler is helpful to find out where is actually placenta is from and the management point of view. So basically what we have to manage it. So prevention is, what is prevention? It is the proper antenatal care. That's what we have to do. It. That is antenatal diagnosis at 20th weeks. So early diagnosis is most important. Early diagnosis, that is during the antenatal checkup that we have to do it. And at about at 20th weeks. And significance of warning hemorrhage should not be ignored. So if any fermentation comes to you in the second trimester, that is 2024, and patient present with that of hemorrhage plus this painless hemorrhage, there is no any pain, then we have to think about that is do not ignore that, don't bother about it. Just do the immediate investigation, that is ultrasonography, that what we have to do it. Then we have to admit the patient. So on admission, what is it is the immediate attention we have to give it. What is overall assessment of the case? It's quickly. What is quickly made as regards what we have to observe now. First important, ABC maintenance. That is, if bleeding is there, so we have to prevent that it should not go into the severe bleeding. So first, for that, what we have to require is the proper assessment. That is, how much is the blood loss. That is by noting the general condition of the patient, pallor, pulse rate, and the blood pressure. So this is a clinical examination. We have to do it. Then you have to ask the history to the patient. Okay, if bleeding, how much clothes are get, or if she's taking the pad or anything, or how much blood loss it is there. Then again, not from the again clinical examination, that is general condition of the patient. Whether the patient is coming in walking, the patient it is collapse condition, everything that we have to observe. Pallor we have to observe, pulse rate we have to observe, blood pressure we have to observe, and blood samples are taken. For what reason? That if any emergency arises, if we require the blood transfusion, at that moment, what we require, it is the blood group we should know, or cross matching is needed, and the proper estimation of HB. Then large bore IV cannula is cited, and an infusor of normal saline is started, and the comfortable cross match blood transfusion should be that is penicillin. Then the gentle abdominal palpation to ascertain any uterine tenderness. So whatever the per-abdominal examination, it is gentle. That is what we have to do to see whether there is any tenderness and auscultation. What we are the auscult? Fetal heart rate. Fetal heart rate. And what we know that in case of this placenta previa, there is no problem with that of approaches. So it is the inspection of the vulva to note the presence of any active bleeding. So just we have to see the vulva if there is any active bleeding, and the formulation of the line of treatment, that is definitive treatment depending upon the duration of pregnancy, what is the condition of mother and the fetus, that is maternal pulse, PP1, and the fetus FHS, and if there is a how much level of extent of the hemorrhage. On that basis, we are deciding for the line of treatment. And what is expected management? What is the aim? What is the basic aim of this? That is, we have to continue the pregnancy up to the full term, that is 40 weeks. For what is the reason? To so that the fetal maturity is takes place properly, and it is not there is no any compromise to the maternal health. Means there should not be problem to the mother, there should not be problem to the fetus, and whatever the growth of the fetus, it takes place properly. And what is it is the conduct of expectant treatment, it is strict bed rest. No any heavy work, no any traveling, nothing. And investigations, what we have to do is if blood loss is there, so we have to do the proper investigation. Then if you require emergency blood transfusion, we have to do the blood group and just urine for what we have to find out protein in that. So why we are finding out the protein? So that we have to roll out proteinuria. If BP is more 140/90, if there is a proteinuria, and if there is a edema, then we have to roll out if proteinuria is there, so that we can roll out preeclampsia. That is the part of PIH, pregnancy induced hypertension. And then periodic inspection of the vulval bags and fetal surveillance with EOG at interval of 2 to 3 weeks. So here what we can say that, during we have to monitor how much is the pads she is using, bleeding is there, or fetal surveillance we have to do it. And for that we have to do the repeated ultrasonography. Yes, what is the repetition? At interval of just 2 to 3 weeks that we have to, that is 15 days or 3 weeks we have to do it. Then, okay, fine, you know that you do the investigation and you observe that the HB level is less. Then what we can think about, we have to give the hematology. Then should be given, and the blood loss is whatever the blood loss. If it is too much of blood loss, then that obviously we have to think about the blood transfusion. If the patient is very anemic, then sometimes it may be steroid for the maturation if the patient is less than 34 weeks. And use of prophylactic, that is magnesium sulfate, can be given for the vaginal bleeding if there is a associated with uterine contraction, that we can use it. And Rh immunoglobulin should be given to all Rh negative, that is unsensitized women. That is we have to give them given the Rh incompatibility. And this is the active management, that is delivery. When the bleeding is there, occurs at or after the 37 weeks. So whatever the management, it depends upon at what level the pregnancy. It may sometimes happens that the pregnancy may be at up to 24 weeks, it may be 30 weeks, it may be 32 weeks, it may be 37 weeks, or more than that. So whatever the management, it is depending upon the gestation period. Second thing, upon how much the condition of the patient, fetus and the mother, and how much is the bleeding that is taking place. So if bleeding is taking place and the duration is 37 weeks of pregnancy or more than that, so near it is approximately 8 months of amenorrhea or more than that. So what we have to think about it is the labor. Patient is in labor, then fetal distress is there, if inpatient is in labor or if fetal distress is there, what is meaning the patient is in labor? If there is a presence of shock or there is a severe pain and the pain it is in the lower abdomen, it is increasing, frequency is increasing, and the duration is becoming less. So means there is a pervaginal discharge with mucus blood is there. Then you can, if the show is there, then you can think about the patient is in labor. These are the signs of labor. And the fetal distress is there. Or if you see the fetal heart rate is increasing, or if there is a torrential bleeding, or if there is if some congenital anomaly is there, which is not compatible with life, congenital anomaly. So, and if there is an intrauterine fetal death, if death has already taken place to the fetus, or if there is a congenital anomaly with the fetus also. So we can think about the cesarean delivery is done for all women with sonographic evidence of placenta previa. There, placental age is within 2 centimeters from the internal os. It is especially indicated if it is posterior or thick. So, but obviously, what you have to think about it is the cesarean section. LSCS we have to lower segment cesarean section. What we have to think about this. And but obviously it leads to the complications also. To complications to both mother as well as fetus also. What are the complications to the mother? That is, it may be complications during the pregnancy or it may be complications during the labor also. And even complication even after the delivery, that is called as a puerperium. What is up to what is time of puerperium? It is up to 6 weeks. Puerperium, that is the whatever the changes which take place during the pregnancy, it comes back to the normal here pre-pregnant state, and it is divided into three parts: immediate, early, and the late. Immediate, that is 24 to 48 hours after the delivery. Then this is early, then immediate, that is 4 to 8 days, and the late, that is up to the 6 weeks. So whatever the changes that takes place to the mother, it is prepared. So this placenta previa is affecting to the mother at 3 levels, that is during pregnancy, during labor, and even after the delivery, that is up to 6 weeks. So what it leads to the complications to the mother? So it may be severe bleeding, that is antepartum hemorrhage, then it may be malpresentation, that is it does not give the proper presentation of vertex presentation, it is other than vertex presentation. And preterm labor. What is preterm? The delivery takes place before the normal term, preterm 37 weeks. That is preterm labor. And during labor, even the labors, there is also problem, that is premature rupture, PROM, premature rupture of membrane. There may be cord prolapse. There may be intrapartum hemorrhage, that is too much of severe bleeding is there, or increased incidence
बड़ी मम्मी को ఒకసారి ఫోన్ చేయి
operative interference,
ఏమో ఫోన్ చేసింది నాకు
postpartum hemorrhage, or there may be if there is a hemorrhage after the delivery, then it may be placenta. It does not come after the delivery immediately. It is the return placenta, and that is the shock. If it is too much of hemorrhage, then it is a shock. Then puerperium. Puerperium means after the delivery, what it leads to? Septic condition. Then it is called the puerperal sepsis. Then subinvolution. What is involution? The uterus, whatever the changes which take place with that, it is coming to normal. But due to placenta previa, it does not come into normal. Sub means below that normal. That is subinvolution. And it may lead to the embolism. And it is not giving the problem to the mother, it is also giving the problem to the fetus. So what is it? Is the LVW. It is what is LVW? It is low birth weight. What is normal weight of the fetus? It is the 2.5 kg and more than that. But if the weight of the fetus it is less than that, that is the low birth weight. Then asphyxia, that is oxygen is not taken properly, not able to reach to the cell of the fetus, and sometimes there is a death. Where is the death? Inside of the uterus. That is called as intrauterine death. And there may be some problem to the there may be problem to the fetus that may be called as a birth injuries. So what may be, there may be different types of the birth injuries, that is cytanohemophilic affected and a number of birth injuries are there. So that can be problem to the fetus. So this is the how can you clinically differentiate between the placenta previa and the abruptio placenta. So in placenta previa, the nature of bleeding, it is painless, while in abruptio it is painful. It is apparently causeless and recurrent, while it is often attributed to preeclampsia, trauma, and continuous one. And it is associated with preeclampsia, that is increase in the BP by 140 by 90 and the proteinuria and the edema. Then this bleeding is always revealed, that is we see outside of it. While in abruption, it is maybe revealed, concealed or mixed variety. Now, common sense we can think about which type of the color. In the placenta previa, it is a bright red, while in abruption, as simple, it is coming from the upside, it is dark color. So general condition, it is the anemia, it is proportion to the blood loss, while in abruption, if it is the consent variety. So we don't know. So it is not matching with that of the anemia with that of the blood loss. That is the out of proportion to the visible blood loss, as in consent and mixed variety. Then preeclampsia in placenta previa, it is not there, not relevant. While in abruption, it is the relevant one-third is. So proper abdominal examination, if you do it, it is the height of uterus, whatever it is proportion to the gestation. That is, if patient is saying that I'm having 6 months amenorrhea, so it is matching. That is 6 months amenorrhea. While in abruption, it is not this matching with that of height of uterus with the gestation period. Then the feel of uterus, it is soft and relaxed. While in case of abruption, there is a tense. Patient is saying, I'm in pain. So tense, tender, and rigid. Malpresentation is very common in placenta previa. While there is the head is floating, that is floating. While in case of abruption placenta, it is unrelated, the head may be engaged. While FHS, it is present, while in this one, it is usually absent. Then the USG, placentography, placenta is in lower uterine segment, with abruption, it is in upper. Vaginal examination, it is placenta is filled on the lower segment, while in placenta is not filled in the lower segment. Blood clots should not be confused with that of placenta. That is what we have to think. So that is management, that what we have seen in previous year. So proper management of all these things, what we have to do is proper management, that is maintenance of air with proper circulation. So delivery, if cesarean section, and vaginal, if coagulopathy present, if fetus is not compromised, and if fetus is dead, then we can think about the vaginal. The short term, if fetus is alive, we are not thinking about the vaginal. So that is what, in short, this revise it. Placenta previa, that is in the lower uterine segment. Second, there are different causes, same like abruption, that is advanced age, multiparity, previous cesarean section, previous history of placenta previa, smoking, and multiple gestation twins. Degrees: 1, lateral, marginal, complete os is not os is closed when of bleeding because placenta, the lower uterine segment is progressively balanced. Then clinical features. Bleeding is there, soft non-tender uterus, whatever the FH is abnormal, high presenting part, and the general condition and anemia is proportion to the visible blood. Proper abdominal examination, what we have to do, exercise of the uterus is managing, vulval inspection, blood clots are present, fresh blood and vaginal examination is contraindicated, you don't have to do it. Malpresentation is present, so do the ultrasonography, different types of ultrasonography, and proper clinical examination, that what we have to confirm the diagnosis, and the management depending upon the first preventive, that is by proper ANC, and management depending upon the gestation period, amount of blood loss, that is whether it should be high to give age, active management, mostly it is the civil section, and if the fetus is there, we have to think about it. It is the vaginal delivery. And the complication both during pregnancy, during labor, after the delivery, and for the fetus also. And difference between it depending upon the clinical examination. It is painless, painful, it is bright red blood, dark red blood, then the height of uterus proportion to it is not proportion to it. If it is present in placenta previa, if it is absent in apraxia placenta, it is mostly in Haemorrhage. In USG, it is placenta in lower uterine segment and here it is in upper uterine. Upper vaginal, fat to lower uterine segment, time in apraxia placenta. You do not have to confuse with that of blood clots. Do the proper management according to the stage. So that's what we have finished about the antepartum hemorrhage, both abruptio placenta and placenta previa. Thank you very much.